Hello, I'm Richard Knight, Vice President of AAKP and Chair of Public Policy. It's my pleasure. We're going to change course a little bit with the next panel. I'm going to introduce two outstanding leaders who are leading the way in advancing patient safety and eliminating barriers to medication access through broad-based national coalitions that value and elevate patient concerns. These leaders know the issues that usually don't affect just one group of stakeholders, which is why our next two speakers have carefully created broad diversity in their respective coalitions they manage. I'd like to begin by introducing a loyal friend of AAKP, Dr. Priti Patel. Dr. Patel is a medical officer who serves as dialysis activity leader with the Division of Healthcare Quality Promotion for the Centers for Disease Control and Prevention. She's the leader behind Making Dialysis Safer for Patients Coalition, which AAKP was one of the first partners and has played a significant role in the development of some of the coalition's tools, specifically the conversation starter to prevent infections in dialysis patients. Our second speaker for the panel is Ms. Patricia D'Antoni, a pharmacist and president of Professional Affairs with the Gerontological Society of America and Vice President of Protecting Access to Pain Relief Coalition, or PAPER. Tricia knows AAKP well from our time together in many Washington, D.C. meetings, from Capitol Hill to the White House, where she has been joined by the chair of the PAPER Coalition and fellow advocate, AAKP President Paul Conway. This coalition also has a diverse group of supporting members aimed at ensuring that Americans have access to and consumer choice for appropriate over-the-counter pain relief while educating the public about the appropriate use of acetaminophen. You may wonder why this is important to AAKP, because as we all know, non-steroid inflammatory drugs, or NSAIDs, are not a safe option for those with kidney disease. So, without further ado, I'd like to welcome our first speaker up, Dr. Patel.
Thank you, Richard, and I'd like to thank AAKP for inviting me to be here today. I'm going to be talking about infections, which is something that CDC cares quite a lot about, of course, and also we've learned over the years that this is a topic that's really important to patients, that they care about infections, and that infections are something that can impact their quality of life and also make it harder for them to go on to get a successful transplant. So I'm going to try to quickly run through some of these topics. I'll give you some background on infections in dialysis patients that many of you probably already know, but I can help to, I think, put some numbers in context. I'll talk about some efforts being made by CDC's Making Dialysis Safer for Patients Coalition to try to address the problem. Some of the things that are being done around patient engagement when it comes to infection prevention, and then also my thoughts on the need for innovation when it comes to infection prevention. So I think all of you, or at least many of you, know that dialysis patients are immune compromised as a result of their kidney disease. They are also at increased risk of infections because of their frequent encounters with healthcare. That's in the dialysis center, that's also during hospitalizations and for surgeries, all of which they have quite frequently. And each of these represents an opportunity for them to acquire an infection related to their healthcare. Of course, hemodialysis patients require some sort of access to their bloodstream infection, and this can serve as a pathway for the introduction of pathogens into the bloodstream and cause infection. As I think all of you know, patients also routinely undergo outpatient treatment in a shared patient care environment, which might be good for some things like socialization, but really isn't good when it comes to preventing spread of pathogens from one person to another. So this is one of the challenges that we face. Another thing that's sort of a reality of outpatient dialysis is that the frontline staff who have most of the direct patient contact with these patients really have no formal education or training in healthcare. And this is yet another challenge when we're trying to ensure that all of the best evidence-based infection prevention techniques are being practiced on a regular basis in these settings. We know that infections are a leading cause of death and hospitalization for dialysis patients. Antibiotics and antibiotic resistance are obviously important topics for CDC and also HHS in general. And we know that if you look at just a 1-year time period, roughly 30 to 40% of dialysis patients will receive at least one course of antibiotics during that time. So it's not unusual for up to a third of dialysis patients to be at risk for getting an antibiotic-resistant infection or being colonized by a pathogen that is resistant to antibiotics. If we look at just one specific multi-drug resistant organism that CDC conducts surveillance for, this is methicillin-resistant Staph aureus or MRSA infections, the incidence of invasive MRSA infections in dialysis patients is several hundred times greater than in the general population. Hepatitis C is another challenge that we deal with quite frequently, unfortunately, in dialysis settings and in dialysis patient populations. So the prevalence of hepatitis C in dialysis patients is roughly 10 to 14% in the United States, and that's compared to 1.3% in the general patient population, the general population. And of all of the healthcare-related hepatitis C outbreaks that are reported to CDC, 57% of them occur in hemodialysis clinics. So let me just restate that again. Of any kind of healthcare-related outbreak of hepatitis C in any type of healthcare settings, and there are lots of them, including formal healthcare settings and informal sort of makeshift healthcare settings, the most common setting for hepatitis C outbreaks that we see is hemodialysis clinics. Bloodstream infections, as I mentioned, is something that dialysis patients are susceptible to by virtue of having to have access to their bloodstream. So there were 29,500 bloodstream infections in outpatient hemodialysis patients reported to CDC's National Healthcare Safety Network, which is a national surveillance system for healthcare-associated infections. This is the number of infections that were reported in 2014. Close to half of those, or 48%, resulted in a hospitalization. Roughly 3/4, or 76%, were considered to be related to the vascular access, and 70% of those occurred in patients with a catheter. So for those of you who are clinicians and nephrologists, I don't think any of this information is going to be surprising to you, but it's impressive the number of infections that there are that occur in this patient population, the extent to which they impact morbidity and mortality, and how much they affect the patient's quality of life. So central line associated bloodstream infections, which are essentially bloodstream infections that can be attributed or related back to a patient's catheter, are substantial for a number of reasons. We have the best data on mortality, cost, and other outcomes related to these. And so the attributable mortality for these infections is very high. There's substantial cost. And importantly, the estimated number of central line associated bloodstream infections, or CLABSIs, in all hemodialysis outpatients is comparable to the total number of CLABSIs in all U.S. hospital inpatients. The reason that this is important is that for many, many years, probably close to a decade, there's been extreme efforts and investments made in preventing CLABSIs in inpatients in hospitals. I don't think there's been the same degree of investment or effort focused on high-risk outpatient populations such as hemodialysis patients. Again, I think a lot of this is information that is very familiar to nephrologists and clinicians, but patients who have a catheter are in the minority when it comes to all patients, all hemodialysis patients, and yet their risk is much higher of getting an infection than say a patient who has an AV fistula or graft. So the bloodstream infection risk for a catheter patient is roughly 8 times the risk in an AV fistula patient. And there's multiple guidelines that recommend use of AV fistulas or grafts instead of catheters for patients who are on hemodialysis. And thanks to the Fistula First initiative and I think other efforts, there has been a decline in catheter use among prevalent hemodialysis patients, and that number is currently around 20%. So roughly 20% of all hemodialysis patients will have a catheter. But where we need a lot more work is in patients who start hemodialysis, and this was alluded to by other presenters earlier today. So upon hemodialysis initiation, that number has been relatively stable. Roughly 80% of hemodialysis patients will actually start with a catheter. And even 90 days after initiating hemodialysis, roughly 70% of hemodialysis patients still have a catheter in place. So catheter use among new hemodialysis patients remains high, And dialysis providers really feel like this is outside of their realm of control. They don't feel like there's much that they can do about this. And so this is an area where I really think that innovative approaches that are targeted towards hospitals, hospital-based providers, and healthcare systems should really be considered. We'll talk more about that when I get to my wish list for innovations. So that was a lot about the problem, and now I'd like to talk about at least one way in which we're trying to achieve a solution, and that's the Making Dialysis Safer for Patients Coalition. This is a coalition that's a collaboration of diverse organizations and individuals, including AAKP, who've joined forces with the common goal of promoting the use of CDC's recommended interventions and resources to prevent bloodstream infections in dialysis patients. So without going into all of the data, I'll give you the high-level version of this. We work together with a small number of motivated dialysis centers who all work together to implement evidence-based recommendations for preventing infections, and they were able to show that they could have a significant impact and reduce the infections in their facilities and actually be able to sustain those lowered infection rates in their facilities by following evidence-based practices. So in the work leading up to the coalition, we learned that bloodstream infections in dialysis patients are actually preventable, and that's something that we didn't know before we started. There's actually a lot that providers can do, including things like improving catheter care that can make a difference in the lives of patients. We learned that improved infection rates can occur relatively rapidly after initiating some of these evidence-based practices and adhering to them, and can be sustained for a prolonged period of time. And there are important secondary benefits for patients, such as reduced hospitalizations and reduced IV antibiotic use. So for many years, we've been focused on getting providers to actually adopt our recommended practices. We've created many tools and resources to facilitate implementation, such as this one. This is a list of what we call our core interventions. These are the evidence-based practices that group of facilities that I just mentioned implemented in their facilities and were able to show had an impact on reducing rates. And I'm sorry that you can't read this, but it's on our website, and I'd be happy to share with you what these are if you'd like. We know prevention is possible. We know how to do it. And we've created all sorts of tools to help with the implementation of those core interventions that we now recommend every dialysis center be using in their facilities. So again, much of our focus historically has been on the frontline providers, getting them to actually implement checklists and other tools to do procedures right every single time. So every single time they're going to connect or disconnect a catheter, they got to do it the right way and hopefully follow that checklist. With the coalition, that has allowed us to sort of take a broader approach and think more broadly about who else and what else influences what happens at that chair side in that interaction between the provider and the patient. And of course, there's lots of these stakeholders that we're very interested in bringing to the table, and patients and family members are certainly first and foremost on that list. So these are the goals of the coalition. The goals are to facilitate implementation and adoption of our core interventions through various means, increase awareness about the interventions, and share experiences and findings through collaboration with other coalition participants. I'm happy to say that at this point our participation has increased to, it's been updated since then. There's actually 66 organizational partners that are part of the coalition. They include many of the largest dialysis provider organizations, professional organizations, patient organizations such as AAKP, ESRD networks. We have a large number of health departments and also federal agencies. We also have a category of individual membership, and we have more than 1,300 individual members who are part of the coalition now. So I know nobody can really read that, but there's a large number of dialysis provider organizations, health departments, and others that we're proud to be able to collaborate with. So when an organization approaches us and says that they want to be part of the coalition, we ask them to submit a letter of commitment that outlines what they're going to do in these different categories of activities. So how are they going to implement CDC recommendations? How will they generate awareness? How will they educate their staff? And how will they share experiences and findings? Next, I'd like to talk about patient engagement, which is connected to what we do in the coalition. So unfortunately, there's not a lot in the scientific literature on patient opinions, perspectives, and engagement in the topic of infection prevention. This is one article that I wanted to just share some highlights from with you. This is a workshop that was done with 8 patients and 3 caregivers. It was conducted in Australia, and they asked patients, these were dialysis patients and caregivers, they asked them to identify topics of importance for inclusion in a clinical practice guideline on the topic of infections in hemodialysis units. So here are some highlights. The participants said that the guidelines should include that all hemodialysis patients should be educated about infectious organisms, including transmission and impact of infection for future treatment. And here when they say future treatment, they're talking about future treatment of their CKD. Patients have a fear of infection. That's something that they reported in this article. They are fearful of not only acquiring infection, but also have a fear of spreading infection to other patients. They commented on the lack of respect for privacy and confidentiality, and it was interesting that even in Australia, the model of dialysis centers is really the same. So there was comment about the fact that in this open unit, providers were talking to them about potentially sensitive or confidential information. And they thought that guidelines should advise upon the manner in which sensitive information is communicated in this group setting. And there was confusion about procedural inconsistencies, which I think will be demonstrated a little bit more clearly with these quotes. So a couple of quotes from this article. Participants felt that patients should be included in prevention and control efforts. For example, one participant stated patients come up with really good ideas. Instead of you telling people what to do to prevent transmission, sometimes they should be telling you. And that's certainly something that we've learned over the past year or so. Patients also remarked that the focus on cleanliness and hygiene was not always clear to them. For example, while the importance of hand washing was emphasized to patients, they observed that surfaces and equipment may not be routinely wiped down. So this is what they were referring to in terms of procedural inconsistencies, that what is communicated to and expected from patients is different than the expectations of staff in that same setting. We recently had a conversation with patients and caregivers at AAKP's National Patient Meeting. There were a total of 8 participants, 2 of them were caretakers, and we asked questions such as, what does it mean to be a patient advocate? Have you ever seen something at your dialysis center that could put a patient at risk for an infection? How do you speak up? Why wouldn't you speak up? And what is the one thing about infection that you think patients need to hear from another patient? So here are some of the highlights from the feedback that we got at this meeting. So very few patients actually considered themselves, patients or caregivers actually considered themselves advocates. However, they defined advocacy as a see something, say something mentality, not just for oneself, but for others as well. And a few participants mentioned that being a patient advocate gave them a sense of purpose, particularly after they had lost their profession when transitioning to dialysis. Unfortunately, all participants had seen things that could put patients at risk for infection in their dialysis units, such as blood on the dialysis chair or the walls, staff using their sleeves to touch the machine to avoid hand hygiene. It was actually quite impressive, the rapid list of examples that patients could come up with when we asked this question. And they mentioned that it's not always easy to speak up, and there are many reasons for this. First and foremost was the fear of retribution, not wanting to correct doctors, and not necessarily being positive of the right way a particular procedure should be done. However, they wanted to learn the right way. As a physician, I've been in situations, and I'm sure many of you have as well, if you're actually in a healthcare encounter and it's not your home hospital or it's not your home clinic, and you're either the patient or you're there with a family member, I have found it difficult to speak up for myself or my family member. And so I feel like this is a huge climb that we're trying to do here, but it's incredibly important. And of course, they said that hearing stories from other patients can be very impactful and very meaningful, and much more meaningful than hearing those messages from others. So we have a patient engagement work group in our coalition, and I just wanted to share with you our aim statement, which is to facilitate patients becoming infection prevention advocates, focusing on the staff-patient interaction and peer mentorship. And we've certainly learned that we can't expect patient engagement to occur if we're just focusing on the patient. It has to be a focus on the partnership between the staff and the patient, such that the staff are inviting patients to be involved and engaged. We also have a catheter care work group, and one of our aims is very much related to patient engagement, and that is changing the dialysis setting culture and empowering patients to care for their catheters in the home. So I think a couple of people have alluded to the fact that with home care, whether it's peritoneal dialysis or home hemodialysis, that there's much more patient education and patient empowerment going on, and there's no reason why that can't also happen for patients who receive in-center hemodialysis. But of course, it requires a major culture shift. So if any of you are old school like me, you might recognize this figure. I don't know if you can actually see it if you're old school like me, but this is where we are now, in my opinion. We're at the bottom of this hill trying to climb up. And at the top of the hill is where we really want to be, with fully engaged patients and family members and a culture that really encourages their engagement. So we have some work to do, and I look forward to hearing from people about how we can get there. So lastly, I just wanted to say, in dialysis, have we come a long way? I'm not so sure. I would argue that the technological advances, at least that you see in this beautiful dialysis center here, are more in terms of the nice flat panel TV screens that are available for patients and the nice laptop that they have available. But in terms of how the dialysis is actually done and the dialysis that's the procedure that's performed, I don't think very much has changed over time. Another thing that I've mentioned on several times in this presentation is that while this is a very pretty dialysis center, from an infection control standpoint, it is a major challenge. We've got, again, a very convenient situation where staff can move very quickly between one patient to another, which makes it convenient for them, but it also makes it very difficult to prevent the spread of pathogens from one patient to another, and that's a major challenge that we deal with. So we would love to see some innovations in that area. Here's my wish list for innovations if I had my way. Number one, I mentioned that we really are in need of strategies to address the high catheter usage among new hemodialysis patients, and that could be in the form of incentives or policy levers that are directed towards hospital-based providers and healthcare systems, not so much the dialysis providers. I think we absolutely need improved dialysis facility design and workflow. This is probably one of the last healthcare settings that is where healthcare is provided in this form that looks like a TB ward that some of you may recall from 1950s. In no other healthcare setting is healthcare provided in this kind of shared group setting from the standpoint of privacy, confidentiality, and also infection prevention. It creates challenges. I think we're very, very behind when it comes to infection prevention technologies and advances, and I'd love to see more innovations in that area, and also more participation in collaborative research. So obviously, the purpose of research is to create generalizable knowledge and to disseminate that knowledge, and I don't really see that happening when it comes to infection prevention, patient safety, quality improvement. And then lastly, I would ask that for everybody who's thinking about technological advances when it comes to dialysis, machines, dialyzers, water systems, any of the above, that you give consideration to infection prevention aspects of those technological advances. And so I think that I'm excited by all of the advances that are occurring, and I think sometimes infection prevention, how would you, for example, disinfect a new machine, is sort of the last thing that people think about. And then lastly, I don't know if this is really appropriate to put in the category of innovation, but bringing it back to patient engagement, as I mentioned, I think that we have a large hill to climb in that, and I would love to see more innovation around how you actually get this patient population that overall is not particularly engaged and is very fearful, how you get them more engaged in their own care. So with that, I will end, and thank you very much for your attention.
So I'm just going to set a timer. Richard's been in the room when I start to get really excited and passionate about this topic, and then usually have to turn around and look at everybody else and say, did anybody else want to say anything? So I want to make sure that I set my timer, but Diana said she'd give me a high sign too. So I was introduced, I'm Trish D'Antonio. I work with the Gerontological Society of America. We are a professional membership organization, and we are happy members of the Protecting Access to Pain Relief Coalition, or PAPER. And I know in the introduction we talked a little bit about the PAPER Coalition, but we were organized in 2015. And my job here today is to talk to you about why it's important that many coalitions that are successful is part of that is the diversity of our membership. So we joined the coalition formed in 2015, and the FDA had issued a report that they had planned to remove any strengths higher than 325 milligrams of acetaminophen to be available for consumers in the over-the-counter market in late 2014 or early 2015. And that was as a result for something to protect the public. You probably remember some issues in public press where there were overdoses of acetaminophen. There was confusion about how to take, so when I talk about acetaminophen, I'm talking about Tylenol. There were some children who had overdosed, right? Because we know that Tylenol exists as itself when we purchase it. It exists in combination products. It also exists in some of your prescription products. So people didn't know how much Tylenol they were taking. Not to mention that some people didn't understand that Tylenol was acetaminophen and also could have been referred to as APAP some places. So there was a huge effort in the medical community with consumer groups to be sure that we educated consumers about that, make sure there was more consistent labeling, make sure that there was more consistency around child dropper bottles and how we talk about a teaspoon, take a teaspoon, and what that means. And that can cause some confusion for people, and making sure that it was measured better. So with all of that, there's still issues where somebody might abuse acetaminophen. If they take too much, it can cause liver trouble. And it could cause some very serious liver damage and lead to some untoward consequences up into death. So rightly so, there was an issue about this. But of course, with every issue, when you take one action, there's going to be some unintended consequences for other populations. And where our coalition formed was because there are so many other people who are impacted by the fact that, well, what am I going to do for pain on a Saturday night if I'm not able to have access to the strength of acetaminophen? How many tablets do I have to take to get that same pain relief? And it really didn't, if you think about it, it really didn't address the issue that maybe the FDA wanted to, because if you could take a 500 milligram tablet and that was going to be enough for you to address your pain, that's going to be enough for you to address your pain. But if the only other option on the market is 325 milligrams, when you take two, you're now taking 650 milligrams. My background, I'm a geriatric pharmacist, or I'm board certified in geriatrics. I'm not an old pharmacist, but and one of the things that's always important for us is we're trying to think about how not to have people on so many medications, right? Because not just the number of different medications you're on, but the number of pills that you're taking, that pill burden, right, which you all know about, can also be a problem and a reason why somebody might not be as compliant, or why it can cause some confusion or trouble or other challenges with your medication. So we formed as a coalition to advocate and to educate members of Congress, to educate and members of the administration about some of the other issues that they needed to consider if they were to remove this strength of medication, and what kind of considerations we thought needed to have. So the coalition, we have 23 members now of different types of organizations. Our organizations are, Paul is our chair, representing the kidney patients. We have other kidney organizations that are members, right? Because of the issue of non-steroidals. We have health professional members. So we have the American Pharmacists Association and the Academy for Preventive Medicine, so representing physicians and nurses. We also have the U.S. Pain Foundation and other pain organizations, because in chronic pain, you need to have a broad armamentarium of both medications and non-medication treatments to treat pain. And then for the Gerontological Society, we were interested for the reason that I had briefly stated and we talked about in my introduction, is that for older adults, you wouldn't want to use nonsteroidals because there are issues around GI bleeds, so ulcers, and issues around cardiovascular events that have been documented. So you need to make sure that you have things available. And what we often talk about when we go on the Hill and we're trying to describe this is, on a Saturday night when somebody has pain, it's not going to be easy for them to go to the emergency room necessarily, because maybe they are an older adult. Travel for them, transportation for them might not be so easy. Their children might live out of town, right? So it's not just an easy an easy jump for them to get there. And there might not be a practitioner available, right? So now they're going to have to go to the emergency room if they didn't have medications available. And also, some of the issues around this that become challenging are that we don't want everybody on prescription medications. We don't want them to jump to opioids or other medications that they might not need to be able to manage their pain. So we started visiting with members of Congress. So we took an organized approach to that. And we met with members of the Kidney Caucus. We met with the Senate Special Committee on Aging. We met with other appropriators, others that had oversight of the FDA, to make sure that they were aware of this issue. And certainly, we heard from staff. They were certainly concerned to hear about this. There were some staff, when you go in and you're educating them, and this is one of the things that's really good about having a broad group of people gone in to visit, is you're not sure which story is going to speak to a staffer. And sometimes, Paul can get through with what he's talking about with his experiences, because he has that direct experience with being a kidney patient himself. Sometimes when we're talking, it's because I can get through to somebody and relate to them with respect to their grandparents and what it might be like for them if they were in pain and they needed to have access to pain, appropriate pain relief. So we worked in 2015, 2016 up on the Hill. We started to then meet with the FDA. And because we were a broad coalition, when we sat down, we actually were able to have successful meetings with the Office of Patient Engagement. And what was remarkable about that is they always brought several members of their team to meet with us. And we met with John White, who just recently left FDA. And he would always comment that when we would come up 15 strong to go visit the FDA and talk to him. And we were trying with his team to work on a project where we could show that we were actually changing the way, changing behavior that that consumers really were getting it about what they needed to do for taking Tylenol appropriately. And we worked with them for about a year, developed a grant. And the grant was a little bit different because we were talking about some gaming theory and behavior change, which was kind of interesting because it wasn't just putting it out there like, okay, here's acetaminophen, here's your doses. People hear that, but you don't know if they really have digested that. We got all the way to the very end, and we did not successfully get the grant. But what was really great was, and this was our big win, is that when they sent us the letter to say, we're sorry, we're unable to fund this, they said, we really don't see this as a priority for us anymore. So now this is over 2 years of doing all this education at the FDA, with the administration, with members of Congress. And while this is not an official document, right? So we don't consider our job fully complete yet. But where we felt successful was in the letter where they said, we're sorry, we appreciated working with you, but we're not going to be able to fund this. But we also don't see this as a priority for us anymore. So we had been able to make enough inroads and education to show them that there were efforts out in the field to be sure that consumers understood how to appropriately take acetaminophen. And we also felt confident that we were able to educate members of Congress and members on the FDA team that the other issues that we might see or might encounter by taking this step would not solve the problem that they were trying to address, which would be to decrease the number of overdoses, and would also impact such a population when you consider the number of people that would be impacted by this, that they felt that this didn't need to be a priority anymore. So we've sort of transitioned a little bit in our work. And one of the things that we've spent some significant time doing recently is making comments to some of the pain task forces that have been stood up from, whoops, there we go. So because of opioids, right, we know that there are studies now that show that acetaminophen is just as effective in chronic pain for your knees, acetaminophen and nonsteroidals as opioids, and you have less poor outcomes as far as side effects go. So we're making sure that that information is out there when we're talking about the opioid crisis, the importance of other medications. And we know that everybody knows that because something's over the counter, it can't possibly work like a prescription drug can. So, and I say that facetiously, but I do know, having worked with some patients, they really feel like they have to have that prescription, or it doesn't, it's not going to work the same for them. But now we're starting to get that evidence that shows that the over-the-counter medications are just as effective. And it's important for people to know that, for policymakers to understand that, for consumers to understand that, and for practitioners to understand that, so that we're sure that we're addressing people's pain correctly. So we continue to meet with Office of National Drug Control Policy. We meet with the White House, and we are meeting with members of Congress still, making sure that they understand the importance of this, and that they still see the strength of our coalition, because we are diverse, because we do come from different perspectives, but we all have this one goal to make sure at the end that the consumer is treated appropriately and has the right medication that they need for the right challenge that they might have at the time. So with that, I'm going to just check my notes, because I noticed I didn't even look at all my notes that I wrote. But I would just say one thing. Since I'm sorry that Paul's not here, but it is a pleasure to work with Paul and the coalition. He keeps it light, even when it gets pretty serious, because sometimes you go into a room and people don't want to hear what you have to say, but he's able to keep it in a way that everybody understands that it doesn't matter what your philosophy is in other areas, because we are concerned about patients at the end here. He's really able to keep us together as a group focused on that mission. So it's really a delight to work with him, and I really do feel honored to be able to work with him. So thank you.
Thanks, Patricia. Dr. Patel. We're going to have a question and answer session now. And again, because it is being recorded, would you say your question? I will repeat it, and we'll let our panelists answer. Dr. Patel, in light of the significant cost of bloodstream infections, particularly in dialysis facilities, one of their biggest metrics is patients going to the hospital. Why do you think they're not more receptive? And if anybody's ever been in here and had her shine that light in a dialysis facility, you'll get a shock. You can explain what the light is. I don't know the technical term. But why do you think that's so? I mean, because of the cost factor alone.
I think there is more attention being paid to bloodstream infections than there has been in the past, and I certainly think that part of that is because CMS is actually measuring it and is actually looking at facilities' performance on the basis of that measure. I wish I could tell you enough of the details of why there isn't more attention put on this, but certainly, the fact that a lot of dialysis care is provided by for-profit organizations makes them not always willing partners in innovative research and in exploring collaborative opportunities to try to improve quality. So they certainly do this on their own. I don't mean to imply that they're not heavily engaged in quality improvement activities internally, but it's just not necessarily shared the same way that hospitals might share or get engaged in that kind of activity. So that's my attempt at being as neutral as possible and not getting too much in the weeds.
Okay.
Richard, a question for Dr. Patel. You mentioned about the expectations or the engagement of patients are so low. What has your research found why that is? What are the factors that are leading to that?
Let me try to repeat the question. Give me the clear version, Kevin.
Yeah. Just trying to understand what are the causes for the low engagement of these patients?
Okay. Again, Kevin Fowler, who's one of our board members, AAKP, is asking what is the reason for the low engagement of patients in some of the facilities?
So I think it's multifactorial. On a very surface level, what we've found is that when we try to interact with patients or engage with patients, there are practical challenges, right? These patients are in dialysis 3 days a week for multiple hours at a time, and afterwards they're wiped out. And so even their time to be able to interact with organizations and engage is very limited. Their ability to travel is limited, and that's all completely understandable. I think that there are other factors such as the amount of education that patients get on this particular topic, I think, is limited. It also could be that we've heard time and time again that patients are overwhelmed when they first start dialysis, that they're not capable of absorbing everything. They don't necessarily want to hear everything all at once, and there isn't a standardized process for maybe coming back to the patient a little bit later with some of this information and trying to reintroduce some of that education or reinforce it. So I think that's some of it. And then, of course, some of the things that we heard at the AAKP meeting about, patients are very concerned about infection. I think that's what we hear from them. They're very fearful of infections, but they're also very afraid to speak up, especially when they feel like their life and their lifeline is in someone's hands.
But I guess I'm just curious, just that fear that they have of speaking up. Any insights into that?
I know we have a lot of patients here, and so maybe someone could speak to that directly.
Well, I mean, the usual reasons. First of all, they have that needle over your arm. And a lot of people don't realize what control that is. And a lot of patients are simply uncomfortable about retribution. And that is something that is very real in a facility, from the chair you sit in to when you get put on. Because it can take a while, depending upon how quickly they may wipe down the chair and get the place prepared. They have some flexibility there. The staff does the best they can, but sometimes they're the staff there that's there to take care of the patients, but they do have limited training, limited time, and limited resources. So I certainly want to open it up for questions from other folks. Yes, sir, Dave?
Opposite with pain warriors. Is it because of the immediacy of their issue? I'm wondering if there's some lesson that you've learned in your community that we can utilize to get our population more engaged with their health.
Okay. Dave White, board member of AAKP, is inquiring, might there be some lessons learned from your community that will apply to us as patients, as dialysis patients and renal patients? Did that summarize it, David?
Yes.
Okay, thank you.
Thanks for your question. So I think there's probably a couple things, and one of them is certainly, and I know this as a clinician, if we dump a lot of information on somebody right at the very beginning, you have to respect that they need some time to assimilate all of that information. What I would say around patient engagement is, number one, and I say this all the time to people, there is no special fairy dust that was sprinkled on me that can't be sprinkled on you to be involved. It's not. Particularly when you're trying to reach members of Congress, policymakers, it is a local piece. You do not have to always be doing a Hill visit. There are many ways that you can be involved as a patient or a caregiver as an advocate. One of the things that we find is really great is when we go in to talk to somebody on the Hill, is when someone back home goes and visits the office, right? So it's not that you have to, I don't want to go to Washington. It's, send a message to congressional staff. They will meet with you. That's what we do, right? we are supposed to be, we are open to serve constituents. And the other piece that I would say is really powerful for us is when we're talking on the Hill or when we're talking at the FDA or in the administration and we say, and we have cumulatively 35,000 Twitter followers, and we'll just put out a message and let everybody know. So social media has really become a big part of being able to become involved. And maybe you're at a different point in your trajectory, so you can't be out, marching. You can't be at a meeting of a member of Congress, but you certainly can write letters. You can write letters to the editor of a newspaper. You can become involved in so many other ways, and social media is one of the strong ways that people have been involved. And knowing that you're all behind us, even though we don't specifically see you in the room when we're there, it does make it a more stronger message for when we talk to policymakers.
Other questions? Well, of course, I have one. Patricia, can you just summarize some of the numbers with respect to pain, whether it be dialysis patients, whether it be some older Americans, or just Americans in the population in general? I don't know if people understand the size of the issue there with respect to that and what the implications would be if they took away our Tylenol. Well, I shouldn't say the brand name, but if they took away the acetaminophen.
And I would say, it's access to the right pain treatment, right? So for us with the Gerontological Society, we're always talking about balanced pain management. And remember that exercise actually could be good for pain management. We happen to be organized around one specific issue with the Paper Coalition, but think about that across the board. And there are other, and we actually see each other at different coalition meetings around this concept of balanced pain management. But just to kind of give you some numbers, we know that over 100 million Americans suffer from some form of chronic pain. That means that they're experiencing pain on a daily basis, and that it's usually a pretty continuous type of pain. So it's not the acute pain when you stub your toe or bang your arm up against the door. For patients with diabetes, where there could be challenges with your kidneys, there's over 25.8 million Americans who could be impacted, right? For people with heart disease, where you have to watch what over-the-counter medication they're taking, you have about 16.3 million Americans. So these are all the numbers that can start to truly impact this. So pain really does affect across the board in some way or another. So we really do try to make sure that members of Congress, that policymakers are aware of this. We all know that we are all aging, and for a geriatric population, we know that the numbers, how many people are turning 65 each day, and for me, I'm also concerned about those people probably 50 and older, because it's what you're doing or what's happening in your 30s, 40s, and 50s that's really going to impact your 70s, 80s, and 90s. Right now we talk about the fastest growing population is the 85 plus population. So that's something else to really consider.
Thank you. Yes, sir, Patrick.
Dr. D'Antonio, do your statistics also cover race and gender? From a mythical standpoint, where society says that African Americans can tolerate pain more than any other ethnic group, is there any documentation to support anything like that, or any documentation to support that women can tolerate pain more than men, or who's using opioids based on race or gender?
Patrick G., our newest board member, is inquiring from Ms. D'Antonio, as to the differences of the ability of African Americans to tolerate pain. Is it a myth? Is it real? Is there any data to support that? Similarly, with women, a similar question.
So thanks for your question. I don't have the statistics with me here today, so I didn't bring that. I do know from participating in other coalitions, there are issues around, it's sort of a reverse issue around treatment of pain. We work with the National Minority Quality Forum on a couple different projects, and one of the pieces that they always bring forward is to remember that there are issues of undertreatment of pain in diverse populations, in particular in the African American community, and that there's no data to say that anybody tolerates pain more or less than anybody from the perspective that you're raising here today. So that we really need to be careful of, that somebody doesn't fall into some sort of an assumption that is not, number one, it's not a fair assumption, and number two, there's no evidence there to support that. We're really concerned to be sure that any decisions, any policy or practice decisions are based on sound evidence.
Thank you. Okay, listen, we're going to end it there. Let's thank our panelists for a very informative session.